So if you're ready to go, I'll do the introduction. So appreciate everyone
Yeah.
joining us for Grand Rounds today, Wednesday, January 29th. I'll start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The people of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So it's my honor to welcome presenter, Dr. Hugo Issa. He's a cardiac surgeon at CHEO and a cardiac surgeon at the Heart Institute and an assistant professor at the University of Ottawa. For his background, Dr. Hugo Issa received his medical degree with honors in 2010 from the Faculty of Medical Sciences of Minas Gerais in Belo Horizonte, Brazil. Thereafter, Dr. Issa completed residency in general surgery at the Clinics Hospital of the Federal University of Minas Gerais in 2013, and a residency in cardiovascular surgery at the Heart Institute of the University of Sao Paulo in 2017, where he obtained his board certification. Following board certification, Dr. Issa pursued extensive training in North America, including 4 clinical fellowships, one in valvular disease at the Toronto General Hospital, 2 in congenital cardiac surgery at BC Children's, 3 in advanced coronary and valvular surgery at the University of Ottawa Heart Institute, and finally, the 4th in minimally invasive and robotic cardiac surgery at the Cleveland Clinic, where he received a prestigious award as the best trainee during his year. In 2023, Dr. Issa joined the University of Ottawa Heart Institute and CHEO. Dr. Issa has been conducting research in the field of adult and congenital cardiac surgery. He is interested in surgical approaches and the treatment for coronary artery disease, heart valve disease, and congenital heart disease. He is also interested in less invasive operative techniques, and he has published over 25 papers in peer-reviewed journals. Thank you for presenting today, Dr. Issa. The title of his presentation is A Perspective from a Surgeon Regarding Research at CHEO. Over to you.
Thanks a lot for the introduction, and good morning, everyone. First, I would like to thank the opportunity to be here today. As a relative new staff in this institution, I began in August 2023. This is an excellent opportunity to get to know you better, and you get to know me a bit better as well. I'm trying to understand how CHEO works regarding research, and I need to find collaboration to develop a strong future regarding research for the division of cardiovascular surgery at CHEO. And I would like to share through this presentation my experience regarding research at CHEO since my arrival. I have no disclosures. In this presentation will have a few topics. We'll begin with a bit introduction of myself. Dr. McNally already said a lot of things. I will try to be quick in this point.
Oh, we've lost sound. Maybe.
Can you hear me?
Yeah, if you lean back, we lose you. You may have to.
Yes, I'm gonna do that. I'm gonna speak a bit louder. Can you hear me well? Good. So, telling that I'm gonna talk about a few topics, and
Oh, you've gone faint again, Hugo. You may have to lean forward.
Can you hear me now?
Now it's strong.
Okay. Thank you. So I'm Brazilian born. In fact, right now I am in Brazil on vacation. I grew up in a big city. It's a 4 million inhabitant city called Belo Horizonte. And Belo Horizonte is the capital of the state of Minas Gerais, which corresponds to the red area in the map. I did my medical school in Brazil, in my hometown, followed by 2 years program residency in general surgery.
Next, I moved to São Paulo, which is the biggest city in Brazil. It's about 18
Hugo, you've
million
gone faint again. We may need
I'm
you to
sorry.
try to stay very still.
Yes, I'm gonna do that. And so I moved to São Paulo to do my residence in cardiac surgery, which was a 4-year programs. This service is the biggest in Brazil. It has about 15 to 20 cardiac surgeries per day, in which 4 to 3 is congenital. And historically, also, it's important to mention that the switch operation was created in this service years ago with Jatin. Then I moved back to my hometown where I worked as a staff cardiac surgeon in a group that had a mixed practice, adult about 60% and congenital about 40%. And due to my interests in pursuing more specialization, I came to North America, which I spent 4 years, and there already spoke about that. My research goals also involved congenital and adult cardiac surgery. And it's important to mention that I'm a clinician, I'm a surgeon, who does researching according to my clinical practice. I'm not a lab person. And now I'm back to Aura since 2023, summer of 2023, where I'm a cardiac surgeon at the Heart Institute, CHEO, and I'm also affiliated with the university. And one of my roles as a professor, assistant professor, is research, which is a nice segue to the next topic. That is finding an idea for a research project at CHEO. I'm going to speak about the folding patch technique to repair partial anomalous pulmonary vein return. So since the get-go in August 2023, when I arrived, I have been trying to fit my clinical practice with potential good research ideas. And I got one idea, which I'm going to tell you further about. When I was a fellow in BC, I saw the former chief operating a kid with transposition of great arteries with a single coronary. During the operation, we made the single coronary diagnosed intra-op. We had no clue that pre-op we would find that. The chief shouted. He wasn't happy about it because it makes the operation more complex. After a few seconds, he calmed down and started to dissect the right subclavian artery. I was puzzled. I was assisting him in the other side of the surgical field. I could not figure out why he was dissecting the right subclavian. And I was even afraid to ask him about it because the vibe was not good at the time. And so I just, stayed calm, observed it. And to make a long story short, we used a short segment of the right subclavian artery, like it's showing the picture C there in the slide, to augment the ocean of the single coronary in the setting of the switch operation. This allows that the coronary will have no kinking and the blood flow will be normal after the operation. If we don't augment and attach the ocean right straight to the neo aorta, usually the right side of the coronary kinks, and after surgery, after pump or in the ICU, we may have major problems with ischemia, RV failure, and things like that. My experience in Brazil was different. In this setting, I had participated, it's a rare series, but I had participated of 2 operations. And what the surgeon, the 2 different surgeons, what they did, they banned the PA, and a few weeks later, they did the atrial switch on the kids. So I got the interest. about the coronary augmentation and look for this technique in the literature. I could not find anything about it. There was a few reports, but not using the right subclavian artery. They had some Safen's vein augmentation for other adult patients, the kids, things like that, but not with that. So I investigate the cohort of patients in BC that underwent this procedure and published in this paper at JT, the Journal of Thoracic Cardiovascular Surgery, this paper. And I also had the opportunity to present this paper in a few meetings. And I got a few feedbacks from colleagues that they're using this technique after they read the paper. This brings a lot of satisfaction for me, and that's the goal of the research. Based on this previous experience that I had in BC, I had the déjà vu at CHEO when I saw Dr. Maharaj repairing on partial anomalous pulmonary vein return. In this anomaly, for those that are not aware, the most frequency configuration is the right pulmonary vein draining to the SVC with an ASD. Like in this picture, can you see my arrow? Can you see my arrow there, Derek?
Yeah, we can see your arrow.
Okay, so this is the SVC. Here is the right superior pulmonary vein draining to the SVC. Here also has an ASD. This ASD in the pulmonary vein drainage cause a left to right shunt that's going to cause RV overload, volume overload, and pulmonary circulation overload. So these patients, almost 100% of them, they undergo surgical repair. And the most traditional repairs for this congenital defect are two. The first one is this one, in which we baffle the right superior pulmonary vein to the ASD using a single patch. So we make a cut in the SVC and right atrium, and then we have exposure of the structures. This is the pulmonary vein draining to the SVC, and here's the sinus venosus ASD. And then with a single patch, we baffle the vein return to the left side of the heart, and then after that, we close. I'm going to explain this repair with this figure. This is a figure showing a normal heart with ASD. So here's the SVC, right atrium, RV, PA. Here's the ASD communicating the right side with the left atrium. Here's the pulmonary veins return. Here's the left ventricle and the aorta. This would be a partial anomalous pulmonary vein return in which the right superior pulmonary vein would drain to the SVC. And here we lost one of connections with the right atrium. And this would be the repair that I just spoke to you about, in which we baffle with the patch the right pulmonary vein return to the ASD, directing the return to the left side of the heart. As any surgical procedure, it may lead to mid and long-term problems. The possible long-term problems are for this procedure arrhythmias, because we manage with the SVC where the sinus node is there. And mainly, we may have some degree of obstructions in the SVC and in the right pulmonary vein return, because these may be not enough long-term wise when the patient grows. This is another technique to fix this kind of anomaly. That's called Warden procedure. This technique was published by Warden and colleagues in '84. And the repair consists of transecting the SVC proximally to the pulmonary vein return. And here, by the way, there are two.
Hi, Hugo, you've gone faint again. I can't really figure out your position relative to the challenges with your audio.
Okay,
Oh, there you're good again.
very, very close to it. And I'm speaking very loud. I'm sorry about that. It might be a problem here in my computer and don't know. But I'm going to speak loud. So we transect the SVC proximally to the vein return. And then we baffle the distal SVC with a patch to the ASD in a way that this return is going to go to the left side of the heart. And the proximal SVC, we're going to anastomose to the right atrium. Usually we use the right appendage to do this anastomosis, directing the SVC venous return to the right side of the heart. If we go back to the picture, this is a normal heart with ASD. The right pulmonary veins connect to the SVC, as I showed you before. During this repair, what we do, so we cut the SVC proximally to the connection of the vein, and then we baffle the distal SVC to the left side of the heart. And next, we connect the proximal SVC to the right atrium, directing the return to the right side of the heart and restoring normal physiology. Mid and long-term problems are the same. We may have arrhythmias, and also we may have obstruction, but now it's mainly here with the anastomosis of the SVC to the right atrium. That's the main site of obstruction. And here, CHEO, so why I had that déjà vu? What have we been doing here at CHEO? Back to our picture. We make an incision in the portion of the SVC and the right atrium. The green draw represents the border of the incision open. We suture a big patch in the floor and walls of the SVC and right atrium and connect this with the medial border of the incision, baffling the return of the right vein to the left side of the heart through the ASD. And then we fold the outer border of the patch and suture it to the outer border of the incision, making the return from the SVC going towards the right side of the heart. It's a bit difficult to understand it in a 2D dimension, so I did this other draw. This is a transverse cut of the SVC and the right pulmonary vein. We do the incision in the SVC, and then we suture a patch in the floor of the SVC and in the border of the incision, making the return from the vein going to the left side of the heart to the ASD. And then we fold the patch and suture the patch to the outer border of the incision, causing an increased diameter of the SVC and restoring normal physiology, because this side here is going to go to the right side and this return here is going to go to the left side. By intuition, rationality, I believe this technique would cause less SVC and pulmonary vein obstruction because we increase the size of the SVC. And the goal of this research is look after the long-term outcomes regarding arrhythmias, obstruction, which I think it's going to be way less than the other ones. And also I want to see residual shunt because it may have more residual shunts because we got to suture way more patch to do this technique. So we may have that. So that's the idea. In this project, was just accepted and approved by RAB. Okay, so we're gonna now collect the data, analyze the data, and after that, we're gonna write our paper and try to publish this in conferences.
You've got a little bit faint right here at the end again, Hugo.
Okay.
That's there. Good.
Yeah, I think I just go back naturally for a few slides, and but I'm back very close to the screen. So now let's talk about the next topic, which is my experience as a new surgeon arriving at CHEO, manage a research project at CHEO. So when I arrived, clinically wise, I knew the environment of CHEO because when I was a fellow at the Heart Institute, I went many times to CHEO to help clinically with surgeries and things like that. However, research-wise, I was lost. I had no experience at all. I arrived in a new land, and I'm still trying to understand how research works here at CHEO. I was feeling like this astronaut in the moon just arrived, new things and so forth. I had a lot of questions. Most of them I already answered, but I still have some. I'm still trying to understand how things work. Nevertheless, I foresee excellence and really good opportunities regarding research at CHEO. The folding patch project has been a learning experience for me. It has been a nice way to understand how research works at CHEO. To get a project to the get-go, through the end, several steps are required. And you guys know this very well. So we gotta analyze the viability, the feasibility of it. We gotta draft a protocol. We gotta have RAB submission approval. We gotta collect the data, analyze the data, and then we gotta disseminate our finds to improve quality in our country and worldwide, sharing the results. And in many projects, there is a feedback that's going to lead to new ideas to make new projects, which this project, it's given me some insights, and I believe I'm going to go more, I'm going to divert the project. As I mentioned before, the folding patch got RAB approved, and I want to share my experience in the steps before. So I'm going to talk about the viability of the project, protocol, and RAB approval, and suggest a few things. Project's totally feasible. It has a low cost. We also have a good number of patients. So we did research with the diagnosed partial anomalous pulmonary vein return in the system, and we believe that there is around 70 patients that underwent this procedure from the late 90s until nowadays. So it's a good cohort of patients. Also, after research in the literature, there is nothing about this technique. So I think this is going to bring our colleagues' attention to our research. And that one suggestion that I would make that probably was a mistake of mine, I suggest to discuss this with all the members as much as possible of your division, because this is going to bring new insights where you're going to predict problems that we may have and things like that. Regarding the protocol, I think the most important thing is to find a good template to make the protocol. This was hard to find. My suggestion is make institutional. Actually, there is, but focus in surgery, okay? And templates so the new researchers can use that. And also, there is a big difference for a research like this one that I just told you about, that's a retrospective cohort analysis, then a randomized trial. So we got to divert the templates and focus regarding surgery. And also, we got to make these templates easily to assess. Regarding the REB submission and approve, I think that was the most time-consuming portion until now, where we are now with this project. My recommendation is always to have someone from the research institute as a guider. I use it. I had the help of at least 3 persons in in-person meetings, virtual meetings, to get to there, and more than once with each one. Also, the Roman system. So in the beginning, it's hard to navigate on it. It's always good to have someone to help you, especially in the beginning. As I told you before, this portion is very time consuming. It took me 6 months from submission, a bit more than 6 months from submission till I got the approval. And it's hard to manage your clinical practice with the research side as well. So most of this delay was actually my fault, but it's something everybody's gonna face. And I suggest to build a manual that's gonna bring the step-by-step for new members and even for current members at our department. Is a picture of the Romeo system. It's a good system, but it takes some time to adapt to it and learn how it works. So it consumed a lot of my time, and it's very important to have and ask for help in the beginning. And lastly, I think there are great potentials to lead projects, research projects at our division of cardiovascular surgery at CHEO. We're going to restructure of our program, and this is a great opportunity to also embrace research in this restructure. We have now a new perfusion team. We have a new team that is building, a new chief that's building our team. And I've been in touch with him with some ideas regarding perfusion, and hopefully that's gonna come true. Also, I think our ECMO program has enough numbers to start to build some research projects in it. And I would count with the ICU team for that as well, and cardiology as well. And especially for me that work at CHEO and the Heart Institute, and I work with adult congenital at the Heart Institute. I also, I'm building an idea project that will study the transition from childhood to adulthood in patients that have congenital heart disease. And once again, we got to take the opportunity of this restructure to enhance research in our division. We're going to have a partnership with Toronto, and I think we can build research together with CKIDS. And there are a few other ideas that I'm working, and hopefully in the next years, this is going to come true. So the take-home messages are, the research opportunities are around, find them, try to fit your clinical path with potential research projects, and build ideas, have these weekly in your mind, oh, this would work, this would not. I think research is quite important to CHEO, the university, and to enhance outcomes in our community. For the new surgeons like me at our department, try to find a simple project to start. This is going to allow you and permit you to learn a lot about the process regarding research at CHEO, as it happened with me, and I shared the experience with you. And I suggest creating a manual to every newcomer at CHEO to facilitate the protocol drafting, the REB submission, and others, to facilitate the process of research of these newcomers. I think a lot of ideas, actually, they die because it's hard to keep moving. And I think this would facilitate, I think, the connection between the the research institute, with the clinical members. It should be easier, and I know everybody has great intentions, but I think we should facilitate this exchange. Once more, I thank you for the opportunity to share my experience here at Grand Rounds. I think research-wise, we're gonna build something strong at the Division of Cardiac Surgery in the near future. And also with the clinical restructure of the program, I'm looking forward to participate, be part of a robust heart center at CHEO and offer excellent results and outcomes and surgery for our community and university. And this is my mail. I'm happy to discuss anything and answer any questions.
Thank you, Hugo. Lovely presentation. The illustrations were fantastic, walking us through the surgeries. You know, on behalf of the ICU, we look forward to working with you on this and other research projects.
That's great. That's great. In fact, the illustrations, a lot of my papers, I have illustrations, and I have a friend from my childhood that is an artist. So I send all my illustrations to him. He's working right now in an illustration for this technique. And I was hopeful I could add that in this presentation, but unfortunately it's not ready. It takes some time, but I hopefully I can share it with you in the near future.
That's great. Sounds like a lovely friend to have. Why don't we open it up to the audience for questions or comments? I'm happy to kick things off. Hugo, you came and went a little bit during your presentation, so you may have provided some of this information as part of it, and I just didn't catch it. But you talked about the sort of the long-term outcomes, mid and long-term outcomes for PAPVR. What are the long-term outcomes of not doing surgery? It would be helpful for the audience to know that. Like, what happens if you don't repair? Often these kids present late or sometimes in adult. So 2 questions for you. Just if you could share with the group what happens if you don't repair, and then second, if there's a difference between the outcomes for presentation when you're a kid versus presentation when you're an adult, and if there's an opportunity to do the study in both groups as a mixed cohort.
So sure. So let's divide it. So the first question is regarding what does happen if we do not repair this anomaly. So I mentioned in one of the slides that this is going to cause a left to right shunt, and this is going to cause RV volume overload, and it's going to cause pulmonary overload circulation. So those are the main issues. So at first, if the shunt is significant, we're going to cause RV dilatation. With time, we may have RV dysfunction. We may have TR. We may have arrhythmias because the right atrium also gets enlarged. We have problems with the pulmonary circulation. So those are the main issues that we may face in those patients that do not undergo repair. There is no urgency in the repair. In fact, we get a lot of misdiagnosis or non-diagnosis in adult patients regarding this anomaly. And there are studies that say that any ASD left to right shunt over time, if the patient takes a long time to repair, usually after 20s, 30s, the life expectancy decrease a bit, okay? So we always try to repair this anomaly when the patient has about 4 years old. And to the other question, we see this at the Heart Institute. There is a lot of patients that do not have a diagnosis when they were kids. They come from other place. They are in remote places in Canada, and the diagnosis just done during adulthood, and we move forward with the repair if the shunt is significant, which is almost 100% of the case.
Thanks, Hugo. Just checking in to see if there's anyone else with questions. I have more questions. Hugo, I'm interested in the concept of sort of the surgical learning curve and how it impacts the ability to demonstrate that one approach or one technique is truly superior to something that's more established. I don't know if you want to comment on that and how it might, whether it could potentially have any impact on what you're proposing to do, particularly when you're looking at sort of longer term outcomes.
Yeah, I think the learn curve, I do not have scientific data regarding that, but it's not stiff. Just a few cases watching and starting to perform. I don't think it's going to change a lot from a person that has done 100 of them, because it's not actually, the exposure is pretty accessible. The exposure is pretty good. That structure is close to you as a surgeon and it's very anteriorly. So technically wise, it's fine. One of my worries is that because we gotta insert bigger and larger patch, and we gotta do more stitching, suturing inside the heart, this may cause more residual shunts. It's something that we're gonna check, analyze this cohort of patients. And as I mentioned in the presentation, I believe the rate of obstruction of the SVC return and the pulmonary vein return are going to be almost none, because we really enlarge that segment where we got a baffle, which is the most common cause of reintervention in the future for those patients. So I think this technique may be quite beneficial for the patients and decrease the rate of the intervention in the future. And by the way, I did not mention in my presentation, but we're going to check the rate of reintervention of these patients. And also, after we analyze this cohort of patients, some idea that I said that we're going to do, it's causing a feedback for a new project idea. My other idea is now compare this cohort of patients with regular ASDs and see, or compare with patients that had the other technical repairs for partial anomalous pulmonary vein return. In this case, I think we're going to need a partnership from other institution. I think CKids could help us with that, because I'm not sure if they're performing this technique there. So it would be a nice way to compare rates of obstruction reinterventions in the long-term follow-up.
Yeah, and I was going to ask about, I mean, Toronto makes a lot of sense given our relationship with them. What about some of the other centers in Canada, or I mean, you've been all over North America. Is there any opportunity for sort of a broader multi-center approach or a registry of sorts, at least within Canada? Is that under discussion at all?
Not now, but I think this project can lead to bigger and further steps. I think a register national-wise would be great, and get that with other centers, BC, Alberta, and Halifax, and others, Montreal, and Quebec. That would be great to give the pressure regarding these and have bigger numbers. So I look forward to, I think this project, it's in the beginning and can generate further steps, step 2, 3, to make something bigger for sure.
Amazing. I don't want all the airtime here. If there's questions from others, or maybe you have some questions for us, Hugo, if you want to use your.
So
this as an
yes, I do
opportunity.
have a discussion to bring, which I think was the reason why I brought this. I think the project itself is too specific to cardiology and cardiac surgery, but I would like to bring the connection between the clinical staff to research. I think CHEO is affiliated with the university, and one of the goals of CHEO is to product research, be productive regarding research. And one of my ideas is to bring this connection. I think everybody has good intentions, but once you start to dig into, it's not as easy as it is. It looks. And I think, is there any way to the newcomers or even current staff to have a better approach with the research institute to facilitate all this process, to make it shorter, things like that? That would be my question, and this I would like to bring for discussion.
So I mean, I'm happy to sit down with you. I don't work for the RI. I'm not a representative of the RI. I'm happy to sit down with you and go through it based upon my experience, Hugo. I'm just looking to see if there's people from the RI present. I see Stephen present, who's with the CRU. Stephen, I don't know if you have any recommendations for Hugo, at least from the CRU's perspective, in terms of how a newcomer can sort of most efficiently engage with and get a project done. Not expecting you to speak for all the RI. I don't know if there's anyone else. So Hugo, I'm happy to sit down with you and talk about it from my experiences. Like I think early on it's about establishing your team. Like you have an idea, which is great, but early on engaging with, for example, I brought up Stephen with the CRU, or engaging with one of the methodologists or analysts at the CRU and getting their input into a protocol. As an example, like when it comes to the REB, I find it they're quite helpful, and particularly if you reach out to them early to understand.
They were in fact quite helpful. As I said, everybody has a great posture and great intentions, but in the practice, it actually takes way more effort than we think. And especially in the beginning, the information, it seems a bit lost, and even the website, it's hard to find all the information that you need, and you gotta meet the people, and you don't know who to look for. Now I know, but I think maybe what we could do is, I'm happy to participate of that, is to facilitate this connection, to facilitate further development of projects for the newcomers and actually to current staffs at CHEO. But yeah, but let's sit down and talk, and will be, I think, a good opportunity to arise some ideas to facilitate this.
There's some suggestions in the chat. Applying for funding for a research assistant. Sometimes the RI has funding. They'll do calls every couple of years where groups, might be an opportunity within surgery or cardiovascular surgery to get some partial funding for a research assistant, as an example. And and then partnerships with people at Ottawa U. Consulate Sergi was brought up. So some suggestions in the chat, but it really is about partnerships and teamwork, and yeah, trying to do it all yourself is hard, Hugo? Particularly when you're
Yep.
at a new place.
Indeed.
Okay, well, if there's no further comments or questions, we'll thank Hugo for presenting, and we'll let him get back to vacation.
Thanks a lot. I appreciate the opportunity to be here today, and in case a further discussion happen regarding this connection, I'm more than happy to participate, be part of this development to facilitate the connection between clinically and research, clinical work and research.
I'm not sure if you can see the chat, but people writing in, thanking you, saying great presentation. So again, appreciate you coming on your vacation, and we'll connect soon.
Okay. Thanks a lot, everybody. Have a great day, and enjoy the snow.